Hello, I'd like to welcome everyone to today's webinar, Classical-like Ehlers-Danlos Syndrome, with Dr. Demirdas. My name is Sarah Jo Ritchie. I am the volunteer coordinator at the Ehlers-Danlos Society, and I'm your moderator today. This webinar is part of our ongoing series, Living with EDS and HSD. This is how today's webinar is going to work. Webinar attendees will be muted at all times during the webinar. However, you are able to type any questions you may have throughout the presentation into the question box at any time. Dr. Demirdas will not be able to see or respond to any questions until the Q&A portion at the end of their presentation. Please do not send your questions more than once. It will not increase your chances of having your question answered. It will only make it harder to sift through the questions and to make sure we can get to as many as possible. Dr. Demirdas is a clinical geneticist at the Erasmus Medical Center in Rotterdam in the Netherlands, who has several publications concerning classical-like EDS and other types of EDS. In daily practice, she sees many patients with different types of EDS. She is part of the International EDS Consortium and is also part of the working groups for the rare types of EDS. Dr. Demirdas coordinates the research for classical-like EDS in the Netherlands and is working closely with medical professionals in the Netherlands, the UK, and Belgium on research concerning both classical-like EDS and vascular EDS. First off, congratulations on your recent achievements and graduation, and thank you so much for joining us today.
Thank you so much, Sarah Jo. Well, as you said, we'll be talking about a rarer type of EDS this evening. The classical-like EDS, which of course all of you know means Ehlers-Danlos syndrome. Sorry. So the first time this type of EDS was reported in the medical literature was in 1997. The report is from the Netherlands, and a group of dermatologists reported about a male, 26 years of age, and they saw this patient because of well, his dermatological complaints. So he had a very hyper-extensible skin, as you can see in the left picture, but also he bruises easily, also has spontaneous bruises, and he has hypermobility problems, which you can see in the middle picture. And this patient was sent to them, and they really thought, okay, this could very well be Ehlers-Danlos syndrome. And this patient also has another condition, which is heritable, and this is called congenital adrenal hyperplasia. So what they saw in his DNA was that he was missing partially the CYP21A2 gene, and this gene is known to cause congenital adrenal hyperplasia. But next to this gene, there lies another gene which is called TNXB. And because he was missing the CYP21A2 gene on both of his copies, so for every gene you have 2 copies, and he was missing part of this gene on both of his copies, but he was also missing part of the TNXB gene on both of his copies. So these doctors thought, well, could this be that his other complaints, so the complaints that he is coming to us for, which makes us think about Ehlers-Danlos syndrome, could this be the cause of those problems that he's having? So the hyperextensible skin, the hypermobility, and also the easy bruising. They knew that this gene, the TNXB gene, was coding for a specific protein called Tenascin-X. I will be calling Tenascin-X at times and TNX at times, but it's the same thing. And they wanted to measure this TNX protein in his blood. So what they did, and these are the 2 pictures that you see below, they measured TNX in his blood, and they here they call him the proband, so the patient is proband here. But they also looked at TNX in a control patient, so somebody who does not have these complaints that we were talking about. And they also measured this in his father and his mother, because if it was indeed caused by the TNXB gene being partially gone, then because both of his copies have this problem, that his father and his mother should be carriers. So they would miss one copy of the TNXB gene, and on the other copy, they should be okay. And what you see here is for the control, so the left picture, you see a black smudge at the 440, and that shows us that the control patient, or the control person, sorry, is making TNX. He or she is making this protein. For the patient, so the proband, we see that there is nothing there. So probably this patient is not making the TNX protein. And then the other side, you also see the father and the mother. So they did the same thing, but now for the patient, the father, mother, and the control. And you can see again the control and the proband. So the patient show what we talked about before, but you can see that the father and the mother, they do have that black blob, but also some smudging towards below, so below the 200 line. And this indicates that they seem to have one TNXB gene that is working and one that might not be. When we come to figuring out if this really is the cause of the disease, the same group of doctors, they wanted to go further and check out if they can actually prove that this Tenascin-X deficiency, deficiency means that something is lacking, so that the Tenascin-X this deficiency is the cause of the disease. And what they did, they looked at 150 patients with Ehlers-Danlos syndrome symptoms, and they also made a control group of patients who did not have Ehlers-Danlos syndrome symptoms. And these were all patients from the rheumatology department, and they were the control group. What they did in all of these, more than 300 people, they looked if they were also perhaps deficient in Tenascin-X. And what you would expect, if it is indeed causative of an Ehlers-Danlos syndrome, you would expect that you would not find it in the control group of around 170 patients, but that you would find it in the group of EDS patients. And indeed, they found in 5 EDS patients, so patients with hyperextensible skin, hypermobility, and easy bruising, they found that 5 of these patients did not have Tenascin-X protein, TNX, in their blood. For the control group, all of them made Tenascin-X. So this made it very much more probable that indeed there was a new type of EDS found, and also probably the cause. What you see on the right are 2 pictures, which are purple reddish, and these are actually pictures of skin cells that have been dyed for Tenascin-X protein. And the upper one is a control patient, so one of the 170, and the lower one is one of the 5 are skin cells of one of the 5 patients with EDS who do not make Tenascin-X. And here you can see proven that the control patient does make Tenascin-X in skin cells, because that's like the reddish, purple, reddish pinkish this coloration. And you see in the lower picture where the Tenascin-X deficient patient is, that those skin cells do not show any red coloration, so no Tenascin-X. And what they also found for these 5 patients is that there seemed to be a different type of inheritance pattern than we actually knew before for the EDS. So I will come back to that later. The same year, interestingly, so the patients until now that were published were all patients who were adults, and this is the first pediatric patient that was published, a male, 7 years old. Again, with the same problems. So you can see this on the pictures, the soft dough-like skin texture, hyperextensible. And he also had hypermobility and easy bruising. And what you see in the middle picture and what they are describing there is the marked absence of scarring on the lower limbs. And this is also an important feature, and we will come back to that later as well. And again, they were able to show in serum that, so in blood, that this child does not, as you can see here. So these are the controls, which make 100% Tenascin-X. The child makes 0%, so the child is this patient. And his father and his mother, yeah, make around 50% Tenascin-X in blood. And that shows that they are carriers. So again, a new patient. What's interesting about this type of EDS is that it's quite similar to the classical EDS type. There are, however, important differences. First of all, the cause is very different. The classical EDS type is caused by problems in genes that code for collagen. And here we see a gene that codes for something called Tenascin-X, a protein. And also the inheritance pattern, which I will go into a little bit more later on, is different than for the classical EDS type. And what's also quite interesting is that there's no atrophic scarring, as I stated before. And another difference that we will get into later, which I did not discuss yet, is that we see distinctive toes and feet in a few of our patients, which can also be a clue as to a patient having the classical-like EDS type. So the classical-like Ehlers-Danlos syndrome, shortened we write clEDS, so classical-like EDS. It is indeed a connective tissue disorder, and this disorder is caused by a complete lack of the TNX protein. TNX, this protein, is a cellular matrix protein. And what it actually does is between the cells there are collagen fibrils, and this collagen gives strength to our connective tissues. And the green here, so this, yeah, you can see here one, there, and there. What it does, it has an architectural function. So it gives strength by holding it together, but also making sure that they can move along, well, the amount that they have to. So a little bit of elasticity for the connective tissue, but also strength. We don't know everything yet about this protein, but it is also thought and also described by colleagues in the field that maybe it has also a role in tissue integrity. Well, if you think about that, it would mean that later on in life you could see worsening of the disease. So if the integrity is not upheld in a right way, maybe you can see even looser skin or even more hypermobility problems. We don't know that very well yet, but that's a thought you could have. And also it is shown that when somebody has a wound in early wound healing, Tenascin-X does not seem to play a role, but in later stages of wound healing it does. And I think that would explain why patients with the classical-like EDS type do not have these atrophic scarring that we see in the classic EDS patients, but why they do have some late wound healing. So not so much the scars that are cigarette paper-like, but it takes longer for wounds to heal. And where do we find this protein mostly? I said connective tissue, but connective tissue, you have to think about skin and tendons. And also it's found a lot in muscles. So these three types of tissues are very much dependent on Tenascin-X, but we also see Tenascin-X to be located around vessels and in the digestive tract. And if you look carefully in the literature, you will also find that there are some thoughts about Tenascin-X being important in limb development. And that might explain some of the features we see on the hands and the feet, which I will talk about in more detail later on. This graph is from colleagues from Italy, and they published about 2 Tenascin-X deficient or classical-like EDS patients last year. And also the pictures are from those patients. And I want you to look at the upper side of this slide, and what you will see are is actually the gene. So the black part, the black boxes or squares, they represent the exons of the genes, so the coding parts of the TNXB gene. And this gene has 44 exons, as you can see. So we start here and we go through to here. And what you see is that there are some numbers and letters at points on these exons. And these are actually variants or mutations, changes in the TNX gene that cause disease. So they lead to disease if you have them on both of your copies. And what interest is very important when you look at this gene, when you have a patient with symptoms consistent with Ehlers-Danlos, the classical type or the classical-like type, and you want to look at the TNXB gene, it's important to remember that, well, there can be coding problems, but there can also be parts missing, or even the whole gene can be missing. So just reading the code is not always enough. Sometimes you will also have to look very closely, are there parts missing? Also, from 32 to 44, these exons, they have another gene, we have another gene, so that's called TNXA. This part is the same when it comes to coding as the TNXA gene, which makes it difficult to look at this gene. And we call that a pseudogene. And when you look and analyze the codes of the TNXB gene, you have to make sure that when you find differences in coding, so variants, you have to, or mutation, just depending on how you would like to call it, you will have to make sure what gene you're looking at when you find this coding difference. So is it the TNXB gene or is it the TNXA gene? But that's of course for your laboratory, but that's important. So the inheritance, I mentioned a few times that the inheritance is different in classical-like EDS when we compare it to classical EDS. In classic EDS, we see a autosomal dominant way of inheritance. So a patient who has the disease has a 50% chance of giving the disease also to their own child. And that means that it is enough to have one copy of the gene to be defected. In the classical-like EDS type, that's different. What we see is that there's an autosomal recessive inheritance. Autosomal means that the gene is on one of the chromosomes that are not X or Y. So one of the 22 chromosomes that have nothing to do with sexual differentiation. This means that both males and females can be affected. What's very, very important is that every gene we have 2 copies because we get one from our father and one from our mother. So also the TNXB gene, we have 2 copies. So what happens when both a father and a mother are carriers of well, classical-like EDS? You see that both parents have one gene with a mutation on it, so a change in the gene that can cause disease, but the other copy that they are carrying does not have any coding problems. So that part of the gene, oh, sorry, that copy of the gene can make the protein, and actually that's enough. So around 15% of TNX protein is enough to not get any problems. We can discuss this later. That's completely true. And when these people, 2 carriers, are going to have children, what happens is that they have a chance of 1 in 4 to get a healthy child. So the gray parts of the parents resemble the gene that is not mutated, and they have 50% chance for a child that has just 1 copy that's mutated, but of course 1 in 4 chance or 25% chance for on a child that gets both mutated copies of the gene from the parents and unfortunately gets classical-like EDS. Now, what we did in 2017 with a group of, well, mostly doctors and one laboratory scientist, we looked at 17 patients with the classical-like EDS syndrome. And what we wanted to do was actually make sure that our colleagues, but also patients maybe themselves, will better recognize the fact that somebody has this type of EDS. And to do that, we did a one day, and on the one day, all patients, all 17 patients came to our hospital, and we talked to them in detail. And we also well, checked them in detail. We did a physical examination. By doing this, we hoped that we would get a better view of what problems patients have. And what was quite interesting, what we were also expecting, because we had some previous knowledge, of course, was that all patients had a hyperextensible skin, which is shown in the lower two pictures, that all patients had easy bruising or even spontaneous bruising, which we call ecchymosis. You can see that on the right two pictures. And 16 out of 17, so all but one patients had also either subluxations or luxations, mostly the shoulders or shoulder or the ankle, and hypermobility. One patient did not show hypermobility, and that was a 66-year-old child. We have not done follow-up yet, so I'm not sure if that occurred at this point. So we will have to say 16 out of 17. But I think these three are the hallmarks of this disease. And to be a little bit more clear about our patients, they had a mean age of 34.6 years, and the range was 6 years. So the child I was talking about to 69 years is the oldest patient of these 17. For 11 patients, we had the serum Tenascin, the blood Tenascin-X looked at previously. So not in this study. We knew that they were all deficient, and we're not making any Tenascin-X. For the other 6 patients, we were not able to do this testing because to check in blood if patients have Tenascin-X deficiency, you need antibodies. We did not have those at that point, and we will talk later about how we are thinking about testing for Tenascin-X deficiency. But for all patients, we did do DNA testing if that was not done yet, or if that was unclear somehow. And for all patients now, we were able to show that they had on both copies of the gene a mutation which causes disease. And also their complaints were very much in line with what you would expect. So there's no doubt that all the patients have classical-like EDS. As I said, we wanted to look in detail at these patients. What I showed you here is actually something that we were very much expecting. So these 3 hallmarks of the disease, we were expecting to find it in most, or at least almost all of the patients. But there were also some interesting things that we found that were not yet described in the literature. For example, here you see some hands, and this is one patient. This is one patient, this is one patient, one patient, one patient. And what's very interesting, we found 4 patients who had acrogeric hands, and acrogeric means that they had old-looking hands. And what I mean with that is that there's excessive skin with excessive wrinkling, and the hands look older than the patient actually is. Yeah? So that's very striking to us. What we also found striking was that there were several patients with broad, short hands and also short fingers, which we call brachydactyly, which you can see here, and also in this patient, broad hands and short fingers. And also for the hands, we saw that not in the younger patient, but the older patients, that they, a few of them developed clawing of the fingers, as you can see here. And also some deformities of the fingers. This is also clawing, I think. I'm not sure, but it looks like clawing. But there were also patients who had clinodactyly. So the finger or part of the finger points somewhere else. So these are some features that you can see in patients with classical like EDS. The same can actually be said for the feet, but I think it's more evident for the feet. We saw this in 4 out of 17 patients. Short, broad feet, especially forefeet was very broad, forefoot, sorry. And we saw short, again, brachydactyly of the toes this time. Just like in the fingers, here is very evident. And we also had one patient who had clawing of all toes, but I don't have the picture of this patient. And what you see here, we call this piezogenic papals. These are actually a little bit of fat coming through the skin. And that's probably because all the pressure is here, and this is indeed a connective tissue disease. This feature you can see in the common population as well, but in our 17 patients, 12 out of 17 showed piezogenic papules, which is definitely more than you would expect. Oh, I forgot something. What I was talking about earlier about the function of the Tenascin-X protein, and it perhaps having something to do with how limbs are developed. Maybe this is in relation to development of, well, actually the limbs, where you see something going different than you would expect. So where you see shorter feet and fingers and toes. So it might have to do something with that. We're not sure yet. This is something we also encountered, and which is quite striking as well. Again, 4 out of 17 patients had edema. And edema means that there is fluid in the skin where you would not expect it. And you can see it here. And this patient is also wearing tight socks to counter the edema. And you can see it in the knees as well. All these patients do not have any cardiac problems that could explain this. And what they told us was that when they are standing for a long time and also when they are fatigued, this would increase. We don't know yet what causes it, but it's something to also keep in mind if you see this in combination with the hallmarks of the disease. Might this be Tenascin-X deficiency? Now, when we looked at all these patients, our goal was actually to make the disease more recognizable for physicians and for patients. So what we also did was in the 2017 criteria for EDS, we also participated, and we formulated some criteria. So these are the 3 hallmarks, again, of the disease, and we call these the major criteria. So when you see this combination, you really have to think about classical-like EDS. So skin hyperextensibility with velvety skin texture, but absence of atrophic scarring. So no atrophic scarring. Also, hypermobile small and large joints with or without recurrent dislocation, most commonly shoulder and ankle, but can be any joint. And easy bruising of the skin or even spontaneous bruising. So if you see in a patient this combination of complaints, you really have to think about classical-like EDS, even though it's rare. Minor criteria means that there are also some striking features in the patients which were less common, but still evidently there in some patients. And actually more than you would expect for it to be a coincidence. Dr. Voermans, she's a neurologist at the Radboud University. She actually looked in a couple of, or in a few patients at their muscles. And the reason she did this was because patients complained of getting weaker, mostly in the hands and in the arms and legs. Also, they complained sometimes of numbness or a change in feeling in the skin of their feet and hands, or even of their hands getting well, less muscle, so atrophy of muscles. And in these patients, she did EMG, also some biopsies, and she was able to show indeed that there seemed to be atrophy of muscles, the polyneuropathy, which is the change, the numbness and the change in feeling of the skin, but also the muscle weakness, which we call myopathy. So this is something to definitely look at, especially in adult patients, but also to keep in mind that if you have a patient which you are thinking about EDS, you see these problems, again, think about classical-like EDS as well. The foot deformities I talked about, the edema, and the hands I talked about. What's also important for the minor criteria is that we do see regularly some patients with vaginal, uteral, or rectal prolapse. Like I said, the hallmarks of the disease should really make you think about this diagnosis. But if you have all three major criteria, so the hallmarks of the disease and also a family history compatible with autosomal recessive transmission, this is very much leading you towards the diagnosis. What is very important though is that there should be a DNA mutation in TNXP on both copies that really makes you think, okay, TNX is either not made, so the protein, or it is wrongly made, so it's not functional. If you do not have this, the diagnosis might be likely, but you have not proven it yet. And I wanted to show you this 2 years later after we published our cohort of 17 patients. Colleagues of us, Ryman et al., as you can see here, they published a woman of age 41 years with also TNX deficiency. And why I'm showing this is that it actually works to look at a larger group, because they are showing us that she has, except for the hallmarks of the disease that we talked about, she has also the edema in the ankles, folding, extra folding on the knees of the skin. But here you see the short, broad, well, short, the forefoot is at least short and broad, and also the brachydactyly, so the short toes. And well, you see, of course, that this is hypermobile, the thumb, but you see a very short pink, so 5th digit, and also some what we call clinodactyly, so the upper part of the finger is pointing towards the side. They showed that in the skin cells of the patient there is indeed a lack or an absence of Tenascin-X, because what you see here lighting up is Tenascin-X. You do not see this here. And what they also show in this report is that the patient has a lot of bowing of the spine, and that's both in the neck and let me see, also in the back and in the lower back. And we see this a lot in patients with hypermobility and especially EDS, because somehow the collagen or the in Tenascin-X patients, the extracellular matrix is not holding up the architecture to give the strength to keep that spine in place, and somehow some patients, not all, they get bowing of the spine. So we've done and learned a lot, but there's still a lot to do and learn. We have research goals. We are working as a group, and I will show you later who is working with us. We have clinical and laboratory goals. Clinically, we want to look even more in detail at the disease to increase recognition and proper diagnosis, but also our main goal in the end is to give good care to patients. So we are thinking about and working on providing clinical care pathways for both patient and caregivers. And for the laboratory, why this type of research is important is because you can look at the disease cause, which can help you properly diagnose the disease, but also better understand why it's even existing and being the way it is. You need laboratory work for this in order to understand it better, and perhaps even, which is of course the ultimate goal, to provide therapeutic options. And as you all know, right now we do not have therapeutic options, we only have supportive care. Well, how will we get to our goals? Our plan is to better understand the spectrum of complaints. So how broad is this spectrum? Is it only connective tissue, or is it broader than that? And how severe is the disease? Is it different in in several people? What are these differences? And is there an impact of the type of gene alteration, so the type of mutation in the TNXP gene, on disease and on severity and the type of complaints people have? So can we perhaps make a prognosis, but also can we better understand what's happening in the body? And what we also need, because I was talking about better diagnosing the disease, is an easy, accessible, and also trustworthy laboratory test. So you have your DNA test, is very important, but what's even more important for those patients where you only find perhaps one mutation and not on both copies of mutation, is to look at Tenascin-X. Is it properly being made? Is it made at all? And especially the word properly is important here, because with the test that we've been using in the past, we can show if there is TNX protein or not, but we cannot show if that protein is correctly functional if it is there. There are some variants that we found in which we think that there is still some protein being formed, being made, but that it is functional, not functional. So you need a different type of test for that. And when it comes to actually making a good clinical care pathway for patients, what you need to know is what are the clinical problems and what is the natural course, because all studies that have been done and all cases that have been published until now, they are cross-sectional, which means at one point in time, we've looked at the patient or patients and we've written it down, but there's no follow-up. So to do that, you will need a patient registry in which you can look at patients at different time points, and even patients can come to you when things change in their symptoms. So that is also something we are planning on doing. And then quality of life, very important. We find that a lot of patients have fatigue. We looked at fatigue also in our 17 patients, and we saw that a lot of our patients have fatigue, but also a part of them, they have severe fatigue, and it affects them. They tell us that they have pain. They also tell us that they have to stop working, or they have to work less. Socially, they are less active, or they cannot do everything they want. So if you know at which domains the quality of life of patients is affected, we hope that you can give better support and more help and better care. So we will be looking into this as well. I was talking about the spectrum of complaints and the clinical problems. For now, we have mostly looked actually at what you can see on the outside and what patients tell you. And we think that other organs might be involved as well. This has not been properly looked at yet in detail, and this is something that we have to do. For the blood vessels, of course, we know the spontaneous bruising and also the easy bruising. But we also have patients who told us that they have red eyes at some point, sometimes, because one of the small vessels in their eyes has popped. Doesn't affect their seeing at all, but they notice this, of course, because then they have a red eye. And for the arteries, there are some patients who have aneurysms in their smaller arteries, so not so much the aorta, but more the smaller arteries. Is that a coincidence, or is that something we should be worried about? We don't know yet. For the heart muscle, there are, to my knowledge, at least 3 patients who have cardiomyopathy at some point in their lives, all before the age of 15, those 3 that I know. And the question is this a coincidence, or is this something that has to do with Tenascin-X deficiency or not? So that's also something you should look at carefully, because you can also give advice about how they should be checked up. So patients with TNX, should you check them once for the heart, or should you do it like every 5 years? Or, yeah, we don't know yet. From the valves, we know the heart valves, we know that mostly the mitral valve is affected. You see a prolapse in some patients, and other patients have insufficiency, but it's all, for as far as I know, always very mild. Less mild, tracheal ruptures and an esophageal rupture. We have seen this in patients. The trachea ruptured in at least 2 patients that I know of after intubation for a surgery. And the esophagus was ruptured in 1 patient that I know of when they wanted to do an echo through his mouth of the heart. And unfortunately, that caused a rupture as well. All patients are doing quite well. So the ones with the tracheal rupture are also fully recovered. This is important. Then when we come to the intestine, there have been reports of patients who have had ruptures of the colon. Also, we think that patients more often have diverticula and diverticulitis, which might also lead to ruptures. We don't know yet. And IBS, so irritable bowel syndrome, which is very common in the regular population, but we also see this a lot in our patients. And we're wondering, is there perhaps some dysautonomia or something that will cause these complaints? Also swallowing problems we have heard about, and motility disorders. But this is also not very broadly looked at yet. So these are all things you can look at. For the muscles, well, I will talk about it in the next slide. The bone, I don't think that there's much of a problem, but it is something that we have to pay attention to, because a paper has been published in which mice who do not have Tenascin-X seem to have some more fragile bones. But I have not heard of human patients who actually have fractures more often. This is work of Dr. Voormans, the neurologist that we work with. Why she looked at the muscles in patients in detail with classical-like EDS, I already told you, but this is also a very important reason why. What you see here is a patient with classical-like EDS, as shown here. She has, well, bowing of the fingers, so claw-like fingers, as you can see. So this actually means that you cannot just, make them right passively. So you cannot do that with your own hands as a doctor. You cannot make the finger right. And here you can see the same thing again. What you also see is some muscle atrophy. So this is very flat here as well. And she was also complaining, as I understand, of weakness of the hands and also the legs. And why Dr. Voormans and her colleagues at that point thought it might have to do something with collagen 6 is because there are 2 diseases, Ulrich's myopathy and also Bedlam's myopathy, which are myopathies caused by mutations in the collagen. Well, the protein collagen 6 is not properly made in these people, and they therefore a myopathy, so muscle weakness, and also contractures, which is the bowing of the fingers or claw-like fingers, is caused. And what they saw in muscle biopsies is that the collagen-6 in patients with TNX deficiency, so the classical-like EDS type, also seems to be lower than in patients who do not have TNX deficiency. So there might also be a function for TNX in regulating different types of collagen. Now, I got some questions over the mail about classical-like EDS and COVID-19. As we all know, unfortunately, we are in a crisis. The whole world is has been or is in some sort of a lockdown. So we were thinking about what's important for patients with classical-like EDS. I think it's very important to please tell your doctor that you are at risk for intubation trauma. Not all classical-like EDS patients will get intubation trauma. Of course not. We know a lot of patients who have been intubated for surgery who did not have a problem at all. But we would like doctors who are, of course, I hope it doesn't happen, the intubation at all. But if it does, it's good if your doctor knows about it. And also it's important that they do a checkup, imaging with radiology, to see if the tube is correctly placed. This is our working group. So we are working with people from the Netherlands, from the UK, from France, also from Belgium. And we hope that we will get more doctors involved from more countries, so we will be able to look at and help more patients. And I would really like to especially thank all patients who participated in our studies, and also all of you for listening to me today. So I guess it's time for the Q&A.
Alrighty, thank you so much for joining us. That was a fantastic and extremely informative webinar. It's always our pleasure to have our doctors and researchers join us, even more so when they share information on some of the more rare types of EDS. Now we got quite a few questions in. We're going to try to get in as many as we can, but feel free, if we don't answer your question live, please reach out to our helpline. They will be able to get your questions answered and right back to you. Okay, so our first question, is there a genetic connection between classical-like EDS and ophthalmology issues such as Fuchs dystrophy?
To be honest, I'm not aware that there is. So as I told you, for the Bethlehem myopathy and the Ulrich myopathy, we have shown that collagen-6 is lowered in patients with TNXP who also have myopathy or other neurological problems. But for Fuchs dystrophy, I don't know any connection.
Alrighty, that might be a question best directed at a helpline. Our next question is there a way we can participate in your studies if we aren't in your country?
That's a good question, and yes, there is. The most important thing then to do is have your geneticist or your well, the doctor you are closest with contact us. And you could do that through the EDS, they could do that through the EDS Society. We are still working on funding to further our research, but we would also very much like physicians from all over the world to get in contact with us, so we can also involve them in the patient registry that we are setting up.
Thank you very much. Good to know. Another question is there any direction in order to accommodate TNXB heterozygous variants of unknown clinical significance as a positive diagnosis of classical-like EDS, especially when the patient is very symptomatic?
Yes, I get this question a lot. And what's important in this matter is that we have to get the diagnostic test that I was talking about to look if somebody's actually biochemically affected. So you can look in, we hope to look in blood, if there's actually a lack of Tenascin-X to answer that question. Because if there is Tenascin-X made, then this is not the diagnosis. And we know from for a fact that testing the TNXB gene is not so easy. I didn't go in that too much, but I discussed it a little bit. So it could definitely be, first of all, that the variant that was found is indeed what we call pathogenic, so causing disease, but we don't know that yet because it's the first time that it's been found, and that the other variant or mutation is missed. So this is possible, but we need a reliable test to check these patients. And we are planning on doing research into that. So at that point, we will also be accepting samples from people with these kind of questions.
Alrighty, thank you so much. Next question. I was tested years ago and had only one deletion of TNXB. This was before the new classification. Since my symptoms have gotten worse, should I go back in for further testing?
Yes, you should. Because as I said, the way that the gene is tested is not as easy as we would wish. And secondly, in our paper from 2017, which is also the year that new criteria came out, we in detail described the problems that we encountered while analyzing this gene. So the laboratory knows better at this point how to check the gene. Yeah. But it could also be that you have something else, because there are also new genes discovered. So it would be definitely worthwhile having that checked again.
That's a very good point. You know, doctors and researchers are discovering new things all the time. So it's always good to go back and look at old medical history and review. Next question. Are there any theories behind the axonal polyneuropathy that is as a part of classical-like EDS? It doesn't typically seem to be described in the other EDS types.
I agree, and I'm sorry, I don't know the answer to this question. We don't know yet, and no, I'm sorry, I cannot answer at this point. I hope to be able to answer this in the future. Yeah.
Alrighty, very much appreciated. Good to know that there's plenty to still research and make breakthroughs with. Is there any connection between late onset non-classical congenital adrenal hyperplasia and classical-like EDS?
Not that I know of, and I saw a paper, I think last month. What they did, they looked at a group of patients with congenital adrenal hyperplasia, whole mouthful. And what they did, they looked at Tenascin-X in the same way that we did in the past to see if that would be a marker for the congenital adrenal hyperplasia. And they did not find any patients who had a lack of Tenascin-X. And to me, that was very logical, because these are two different genes. So if you have specifically mutations in the CYP21A2 gene, so not the TNXB gene, and there's not a deletion that causes, like the first patient I showed you from 1997, that there's part of the TNXB as well as the CYP21A2 gene missing, then I don't think that patients with CAH will show any symptoms of Tenascin-X deficiency. And something I did not mention in my talk is that we found that actually all our 17 patients had an onset of disease in childhood. So I would not expect this to have a later onset.
Alrighty, thank you so much for that clarification. Next question. I think we got time for maybe 4 more. We'll see what we could fit in. How does one go about getting tested for lack of TNX? And if you don't have a low number, do you not have classical-like EDS?
Yeah, good question. Let me think about how to answer this. How do you go about it? Well, at this point, we don't provide the test. We are going to set it up. So in the future, I will hopefully within a year, we'll be able to provide testing on research basis. The type of testing that I discussed previously with you in my talk with you about blood testing that has been done in the past. There are some colleagues, like the colleagues, the last patient I showed, the one from 2019, they still do staining for Tenascin-X. We do not. But in the future, we will be providing this type of test. And if you do not have a lack of Tenascin-X, the chances that you have classical-like EDS is very low, except what we think and what we hope with this new test to be able to look at. We think that there are some mutations that give an altered protein. So the protein, there is still a protein made, but this protein is not functional. So what we want to do with this new test is to also find these type of proteins. So a protein that is still made by the TNXP gene, but which is not functional. And I can imagine that if you use the old test, you would still think, okay, this patient is making Tenascin-X because I'm seeing TNX in their blood or in their skin cells. But this might not be functional and you will not know. So we are looking for a better test.
Thank you so much.
I hope that was clear because I was a bit looking in my head for the answers.
It was absolutely perfect. Thank you so much. Next question. My daughter cannot get in for genetic testing yet. Her rheumatologist feels that due to her skin and other symptoms, that she's most likely classic EDS or hypermobile, but he says the management would be essentially the same. Does it matter? And which it is? Do you concur, or should we try to get tested?
I do not concur. If you really think that it might be classical EDS, I think you should get tested. And the reason is that for the hypermobile types, whether it's HEDS or the spectrum hypermobility, usually you do not look at cardiac problems. These people do have problems with gastric emptying and also motility problems of the esophagus. But these are worse in patients with classic type of EDS. So I disagree with this rheumatologist.
Alrighty, thank you so much. Hopefully that helps that family out. Do you know any doctors that are willing to test for classical-like EDS and not just vascular? Is there a certain doctor, a genetic counselor, rheumatologist that might be more apt to do genetic testing for classical-like?
I don't know. I need some more information for this question because we, how we work is you see a geneticist if you have not just problems consistent with hypermobile type of EDS or the hypermobility spectrum disorders. So if there are also skin problems, everything that we know of, then you go to geneticist, and based on that, we usually do a package of genes that we look at. So this contains actually all genes that are associated with EDS at this point. I think if you see somebody with hypermobility problems, etc., consistent with either classic EDS or classical-like EDS, you do not have a reason to look at vascular EDS because those patients usually are not hypermobile and usually do not have hyperextensible skin. They have very different problems. So, yeah, I don't know why you would look at vascular EDS and not the other types when the problems are consistent with the classical type or the classical-like type.
Alrighty, thank you for that clarification. If there is only a heterozygous mutation and the person is currently diagnosed with hypermobile EDS, should you look further into classical-like EDS?
That depends. Are there also skin problems in like true hyperextensible skin? And also really other hallmarks of the disease or the minor criteria. If there are, I think you should. If there are not, there are some theories about this. It could be that it has nothing to do with the classical now I have to say this again. It could be that it has nothing to do with the genetic change that has been shown in TNXP and the hypermobility, because hypermobility is quite, as you know, common, and the classical-like type EDS is very rare. There are around, now, I know a maximum of 50 patients in the whole world at this point. And hypermobility spectrum disorders is around one in 5,000 people. So that's a large difference. So the chances are that it's just hypermobility spectrum disorder or HEDS. But there are also colleagues who have described and think that hypermobility could be caused by heterozygous mutations in TNXP. If that is true, I don't think that would change anything for you. I don't think that would change the way you are being treated. And also, I don't think that would give you like a higher chance on all the organ problems that might be important for the classical like EDS.
Alrighty,
So I
thank you
think
so
you
much.
should test further if there are more, if there is more evidence in your complaints and in your problems that this is indeed classical like EDS and not just, well, not just, but not the whole hypermobile spectrum disorder.
Alrighty, thank you so much for that one. I think we're going to try to squeeze in one more because I know this has come up through a few emails to the helpline. Do you know of any company, any commercial company doing commercial serum TNXP testing, or is it purely a research kind of test without real world application?
TNXP or TNX? Is it the gene or the protein?
It says, let me clarify. That's a very good question. TNX.
Although I'm not sure if it changes my answer though. I mean, I don't know of either. And is this a research type of thing? No, to me it's not, because usually we pick up patients in a diagnostic setting and not a research setting. The patients that we really pick up in the research setting are those who have symptoms and maybe just one variant, so one mutation heterozygously. So it's not as a clear-cut case, let's say it that way. Those are the patients that we pick up in research, but all the others are diagnostically. I don't know though of any commercial companies, no, but there might be. I just don't know about it.
But to follow up with that, I know we've heard from a couple patients that they've gotten false results from tests from places like Ancestry. So as a geneticist, how do you feel about somebody going to a commercial company like Ancestry, 23andMe to find testing for this versus, you know, going to see an actual geneticist?
Yeah, I understand that people do that, especially if a geneticist tells them that they don't see any reason to do genetic testing. But the thing is, if you go to geneticists, you get educated, specialized answer. But when you go to commercial companies, first of all, it's not very important to them what they give back to you. Because they want to make money. That's their primary incentive. And also, they are not as good as your diagnostic tests, because what they do is they look at SNPs, and SNPs are just specific codes in a gene. So they would look at a package of SNPs, and in that matter, they will not look at the whole gene. Also, finding anything in genes without a proper diagnostic look from your geneticist, so a clinical look, that might leave you just confused, and would also maybe cause a lot of grief, because you have complaints, something is found in a gene, nobody knows what it means, and what are you supposed to do with it? So to me, the commercial companies are exactly what we call them. They are commercial companies. They are not meant or their incentive is not to help people with their complaints or with their health issues.
Alrighty, thank you so much for that one. But unfortunately, that's all the time we have for today. If we did not get to your question, please reach out to our helpline. That is www.ehlers-danlos.com/EDS-helpline. They will get back to you. They will help you find resources, answers, whatever you can think of to ask. They will get back to you relatively quickly. But if you would like more information about anything else that was presented today, please check out our website for more resources and information. Like I said, give our helpline a call or an email, and definitely consider signing up for our newsletter if you haven't already. It's a fantastic source for the most up-to-date information and upcoming events. Our next webinar is actually tomorrow, so we're doing 3 in a row. We have our very own Marisa Bergfield joining us for a very special webinar titled Managing Mental Health in Stressful Times. We know that many in our community are feeling overwhelmed with the current global situation, and we want to provide a safe space for our community to talk and learn about practical ways that you can take care of your mental health and ways to deal with events like COVID-19. That registration is up on our website, and it's also on social media. And I just want to say thank you so much for joining us today. Your presentation was extremely informative, very insightful, and technology permitting, this webinar should be available on our YouTube channel within the next week or so after it goes through post-production, barring technical difficulties. But if you found this webinar helpful in any way, please consider hitting that like button once the webinar is available on YouTube, and then subscribe to our channel so that you can be alerted to when we're uploading videos. I'd like to thank everyone for joining us today. I hope everybody is staying as safe and as healthy as possible, and I hope to see some of you tomorrow. Have a great day.